Okay, hello everyone. Welcome back and welcome to chapter 2. In this chapter, we're going to take a broad look at how healthcare is delivered in the United States. We'll look at the history, we'll explore the structure of the healthcare system, we'll talk about the different levels, different models, the different types of care, the wide variety of healthcare entities that provide services. We'll talk about hospitals, we'll talk about long-term care, and some of the emerging things that are impacting healthcare and health information management, such as telehealth. We'll also take a look at the many professionals and providers that exist. In fact, for that point, we'll talk about what exactly do we mean by a provider and how they fit in with patient care along the continuum of care. Then we'll take a look at how government policies, legislature, technology, and other factors influence healthcare operations and particularly health information management. Let's have a look and get started on chapter 2. So again, this chapter covers healthcare delivery systems. And again, healthcare delivery systems are constantly evolving. If you think about just within the last 5 years, we have such things as telehealth modifiers, AI in healthcare, and many, many other things that didn't exist as little as 5 years ago. However, some things have existed, and these are highlighted on this first slide. We always had providers, which are not necessarily the same things as physicians. We'll get into that a little bit. We also had entities, in other words, different organizations. We had regulations, and we had technologies. Before we get into all that, we need to take a look at where we've been so we can understand where we are and where we may be going. And early healthcare in the United States was primarily home-based. You had physicians coming out and making home visits, and really wasn't a big dramatic thing, as most hospitals were places where people just went for rest and maybe had some simple procedures done. And again, a lot of these treatments that were done, a lot of these procedures were based on remedies, traditional medicines. And a big challenge was what you see in the fifth bullet point down was infectious diseases, malaria, diphtheria, smallpox, yellow fever. And families had many children because frequently at least one child or two would die. The medical education, for that matter, all health related education was lacking standards. There weren't really that many advanced treatments. There were amputations for an infected leg, but nobody could really do a procedure to drain an abscess at that point. With the Civil War, we had a need to treat a large number of war injuries. And so this kind of spurred interest in surgical techniques, research, the rise of nursing as a profession, and some of these other things, the importance of sanitation as it relates to healthcare. And this led to the appointment of the Surgeon General and the formation of health-related agencies. With society becoming more industrialized and more mobile, this created a need for more industrialized and mobile society. We had the professionalization of healthcare being done now as a profession. We had hospitals being formed. We had medical advancements. We had the scientific method. We had cell level research. Then we had insulin, vaccines, CT scans, MRIs. And then here in the United States, of course, we had managed care, health insurance, and healthcare reform initiatives. Some of this reform is still ongoing. Some things that are facing us now that we've covered where we've been, where we are, and where we're going, is the population has turned grayer. The population of those over 65 is projected to exceed children and adolescents under 18 by 2040, not really that far away. As we age, we use more healthcare services, so we'll have an increased need for healthcare services, specifically those with chronic diseases and functional decline, meaning things like Alzheimer's, dementia. And we'll have an increased number of older adults leaving the workforce, and this includes physicians, nurses, and others. Here in Lane County, Oregon, we've had a mass exodus of primary care providers, particularly from the Oregon Medical Group, and this impacts healthcare delivery systems, both inside and outside of Lane County. We have the Healthy People Initiative 2030, which are some objectives for improving health and well-being nationwide with a focus on decreasing deaths through the lifespan of people and increasing independence amongst older adults. Something that we will talk about in coding and some of our other courses is the social determinants of health. And basically what this is, these are economic, education, location, and other social demographics and how they determine health, right? If somebody doesn't have a job, they don't have insurance, so they can't do cancer screening, so on and so forth. And a lot of interest in this area. We also have the continuum of care, which we've talked a little bit about in other courses, primarily the introductory course. But if you think of it as a continuum, right? We have preventative care, we can have people get diagnosed and what have you. Then we go through diagnosis and treatment. Somebody has an illness, say they have cardiac surgery, and then they go to cardiac rehab. So we have that. And then at some point, we have the inevitable. We have death, end of life care, and so on. So along this, it's helpful to think of it as a continuum. It's not one size fits all. We may move back and forth between different parts of the continuum, go from preventative care to diagnosis and treatment, and so on. We also have specialized types of care, and they're on 4 different levels for the most part. We have primary care, we have secondary care, tertiary care, and quaternary care, right? Let's take a look at each of these. And with types of care, we also have acute care. This is something that's happening right now, right? So when we think of acute care, we often think of, we often think of inpatient care, and subacute care, we think of outpatient care. But related to that, we also have rehab, long-term care, we have custodial nursing care, home patients, we have home health care, and then we have hospice. Hospitals are basically a place where a patient gets admitted and stays overnight for a period of time. According to the American Hospital Association, the AHA, they define hospitals as licensed institutions with at least 6 beds. Licenses being permission given by the state government to function as a hospital. Its primary function is to provide diagnostic and therapeutic patient services. Hospitals also have some sort of medical staff and can provide some sort of continuous nursing services. When we talk about hospitals, a way we like to classify them sometimes is by their average length of stay. And so if we have a group of patients that have an average length of stay of 30 days, they're not considered acute care. So if they're 30 days or longer, it's not an acute care hospital. So in this case, if we have an average length of stay, what does that exactly mean? Well, that's a ratio or an average that we look at to say how long patients are staying in the hospital on the average. And we're looking at the total number of days for all inpatients, and we're going to divide that by the number of discharges and multiply that by 100. Your book here says number of admissions or discharges, but if you think about it, it makes sense because everybody gets admitted to a hospital, ultimately gets discharged. And again, a lot of interest, a lot of discussions in the news, both nationally and locally, about hospitals. Here in the Eugene Springfield area, we've had the University District Hospital close, and that's led to impacts with Peace Health Riverbend. Hospitals in the United States are 17.3% of the total American economy. So what that means is it's just under, if you will, 1 out of 5 dollars being spent, and it's supposed to get almost to 20% or 1 in 5 by 2032. Hospitals are increasingly becoming part of a system, the Peace Health system, the Providence system, the Kaiser Permanente system, the University of California system. And these are basically 2 or more hospitals that are owned, leased, sponsored, or managed by a central organization. They typically have some sort of integrated delivery network. You might have an organization like Kaiser that's very integrated with hospitals, medical groups, home health, and what have you. It might not be so integrated, but basically it's a network of health entities under the same ownership that provides services in different settings. Another way we can classify hospitals is by the bed count. This is basically the number of beds that are set up and staffed for inpatient care ready to go. The bed capacity is similar, but not the same. It's the maximum number of inpatients that a hospital can provide care for. And then licensed beds is the number of beds that the state has authorized the hospital to make available. And then staffed beds, of course, are the ones that are available. So you can have a higher number of licensed beds and a lesser number of staffed beds in the same facility. And here's some interesting graphics on the average bed count per region. Note in the West that hospitals are fairly large at an average 127 beds per, right? And you can also see average bed count 25 or fewer, and so on. We also look into hospitals as being for profit and not for profit. The Reader's Digest version of this is that hospitals that are for profit, like any other organization, you have your revenue that comes in from payers and other sources, CMS and what have you. You have expenses, and then after you've paid all your expenses, paid all the taxes, right? You have profit. Well, what happens at profit? With a for-profit hospital, it gets dispersed to the investors. A nonprofit hospital has the advantage of not paying federal income or state or local taxes, but the profits get reinvested into the hospital. So just because you have a nonprofit healthcare organization or hospital doesn't mean that people are working for free. You can still have highly paid executives and other staff, but you're not putting your profits back into the hospital. So that's the big difference. Critical access hospitals are hospitals that are 25 or fewer acute inpatients and are located more than 35 miles away from another hospital, or 15 miles if it's in mountainous terrain. It has to have an average length of stay of 96 hours or less for acute care and have a 24-hour emergency room. A rural emergency hospital has Medicare provider designation, and it has to be 50 beds or fewer and be a critical access hospital. A lot of discussion about what will happen to critical access hospitals with the new big, beautiful bill that's been signed into effect and the resulting changes to Medicaid. Hospitals typically have a board of directors who essentially have ultimate authority and responsibility for the hospital. They have a medical staff, they have a chief of staff, they have departments, they have medical staff bylaws that the credentialed medical staff who have privileges there are all in agreement of, that kind of governs their conduct. And then, like any other organization, you have administration. You have a chief executive officer, chief financial officer, chief operating officer, nursing officer, and so on. Hospitals and administrative staff support services do the non-provider patient care activities. Hospital-based outpatient ambulatory care services are basically what it says. It's hospital-based, but they're doing outpatient ambulatory care services, x-rays, procedures, and what have you. We also have different levels of emergency and trauma services. So all these things that are listed here fall under the global umbrella of hospital care. We have other healthcare entities, excuse me, that are mentioned in your text. We have managed care organizations. We have accountable care organizations. We have ambulatory care, urgent care, and private medical offices. We have other things that are coming more prominent now with people living longer. They're not sick enough to stay in the hospital, but maybe there's interest in long-term care, medical home, different agencies, adult daycare types of things. All these things are other different types of healthcare entities. And of course, if we're going to do that, we're going to need employees or workers. Let's take a quick look at this one. In primary care, you may not see your family physician anymore. You might be seeing a physician assistant. These are somebody with a bachelor's degree in health sciences and later goes on to pass an accredited physician assistant program. And they kind of work almost like a nurse practitioner under the broad supervision of a physician. We have PTs and OTs, we have HIM professionals, and so on. And speaking of physicians, we have other things that we need to take a look at. Physicians typically have a bachelor's degree in the sciences, and then they become go to a medical school and they receive a doctor of medicine degree or MD or a doctor of osteopathy, a DO. Once they do that, they specialize in something, right? And this is called their residency. At the end of their residency, they sit for board exam and then they become board certified in internal medicine or emergency medicine or surgery or what have you. A hospitalist is somebody who typically is an internist that just takes care of patients when they're in the hospitals. And then within that, we have different medical specialties and subspecialties. So going back to the hospitalist, you may have somebody who's not only a hospitalist with certification in internal medicine, but they also have certification in the NICE in intensive care medicine. You could have a surgeon who has board certification in general surgery, but then they specialize in cardiac surgery or thoracic surgery and so on. We've already covered physician assistants. Nursing is one of the largest segments of healthcare workers, as we saw in that earlier slide. And nursing can take a couple of different formats. We can have certified nursing assistants, we can have licensed practical nurses, registered nurses, advanced practice registered nurse, or somebody who's a nurse practitioner who almost functions independently, but under the broad supervision of a physician. There I am. And that's all I have for you. Tune in to the next video lecture where we'll talk more about health information management and other topics regarding the healthcare delivery system here in the United States. Bye now.